Hi everyone, my name is Stephanie Griffith. It's an honor to be speaking to you today on behalf of the Sepsis Alliance. The lecture today is Personalizing Shock Resuscitation Using Dynamic Fluid Responsiveness Measures. And before we dive in, let's go through my disclosures. I am a Principal Medical Science Liaison in the Medical Affairs Division at Baxter. I'm also an Assistant Nursing Professor at Simpson University in Northern California. And I was recently a grant recipient from an Interfaith America Religion and Health Curriculum grant, so that's unrelated but still necessary to disclose. All right, so for today's objectives, we're going to review the pathophysiology of septic shock. We're going to review current literature in the management and treatment of septic shock, discuss early vasopressor and fluid resuscitation strategies that may improve outcomes, and then also learn how to personalize care of the septic shock patient using dynamic fluid responsiveness measures. All right, so why are we talking about patho? Well, our patho actually is so important here because our treatment in septic shock is predicated on the patho. So infection creates inflammation, right? This inflammatory state, which releases vasoactive materials and toxins into the blood. That makes our vessels vasodilate, and then our fluid leaves our vessels. Our blood pressure drops, and our heart tries to compensate then by increasing our heart rate. This is all very familiar to us. Fluid continues to leak, and blood pressure drops even more, and then cardiac output is not enough to meet the basic metabolic demands of the body. So this is a 10,000-foot view and a gross oversimplification, but it's important for us to remember what is actually going on in the body when our patient is in septic shock. So again, our treatment is predicated on that pathophysiology of sepsis and septic shock. So that's where we get things like our weight-based fluid guidelines, right, from the Surviving Sepsis campaign. So we want to replace the intravascular volume that the patient has lost. So we suggest that at least 30 mils per kilogram of IV fluid should be given within the first 3 hours of resuscitation. So in this lecture, we don't have enough time to talk about timing, but the idea here is that what we're finding is earlier treatment is actually better. It leads to better outcomes for patients in terms of antibiotics and fluid resuscitation and where we're headed today, which is with early vasopressors as well. All right, we could have an entire lecture just about fluid choice, but that is one thing I just want to mention really quickly, that the Surviving Sepsis campaign guideline updates have also, because of your SALT trial and your BASICS trial and different studies have shown that there is a mortality benefit to not fluid resuscitating with normal saline, which some clinicians actually call abnormal saline. I'm not trying to throw any shade on any solutions, just repeating to you guys what the new recommendations are: balanced solutions instead of normal saline for fluid resuscitation and sepsis. So as time goes on and we continue to study fluid choice, fluid amount, and how to actually guide that fluid, vasopressors, then I know the guidelines will continue to update. So recently we also had classic and clovers, those trials that published data showing that a one-size-fits-all approach to fluid management actually does not change or improve outcomes for patients. And one of the important things to talk about is the fluids and this Bellamy curve. So we understand that there are consequences with over and under fluid resuscitation very broadly. We know that if we don't give our patient enough fluid, that we're going to have hypoperfusion, and we know if we give our patient too much fluid that they're going to become volume overloaded. But what is really important here and what's bearing up in the literature that we need to pay attention to is that fluid overload specifically is associated with worse outcomes, and guiding fluid management using dynamic assessment, dynamic parameters, actually does improve clinical outcomes for patients. So these are pieces of data that are being added to our conversation around how much fluid do we give, how much fluid is too much fluid, what type of fluid do we give, etc. Early fluid overload specifically is associated with worse outcomes in all of these different patient populations. So again, something for us to be aware of as we're going to fluid resuscitate our patients. All right. Another surviving sepsis campaign guideline update. So for adults with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. So a static parameter in this case would be something like a blood pressure. And no one's suggesting we take away blood pressure. I think that's just silly. But I do think we need to understand the differences between pressure and flow. And we also need to understand how blood pressure is a late indicator that a worsening or developing perfusion problem is actually occurring in the body. The other really important piece of information to continue to remember when we are talking about patients in septic shock is that only 50% of hemodynamically unstable patients are actually going to be fluid responsive. So what does this mean? So let's say your patient came in, they met the surge criteria and had the presence of a known infection. And so they got the lactate, the blood cultures, the antibiotics, and then the weight-based fluid. We're in our full-on pathway for treatment. After the weight-based fluid, what this literature is saying is the patient, if they are still hypotensive, i.e. hemodynamically unstable, that fluid only has a 50-50 shot at that point of increasing their cardiac output, so further fluid. So the idea here is that we don't know if a patient is a fluid responder or not just by looking at blood pressure. We don't actually know by looking at heart rate. We don't know by looking at doing a physical exam. We actually would have to challenge the heart with a little bit of fluid and observe the heart's response to the fluid. That is what a simple definition of a dynamic assessment to determine, can this patient tolerate more fluid at this time? Fluid responsiveness does change, and we're going to talk about that as well. All right, so if we're starting to understand that dynamic assessments might be best practice, then we also need to understand what dynamic assessments are. So a dynamic parameter is, notice it says, include response to a passive leg raise or fluid bolus using stroke volume. That's the first one. So looking at stroke volume index percent change in real time in response to a PLR, a passive leg raise, or a fluid bolus would help you determine if your patient was a fluid responder, and we'll go into this just a little bit more. Stroke volume variation and pulse pressure variation, also accurate as long as you're meeting the core criteria, your patient is intubated, they're in a normal sinus rhythm. That can be difficult to implement in clinical practice just because of how irritated the heart can get. Nevertheless, they are accurate, and if your patient is in a normal sinus rhythm and they are intubated and they are breathing a particular amount of tidal volumes, then your SVV and PPV are considered dynamic parameters, or echocardiography where available as well. And you actually can do a passive leg raise using echo as well. So if your clinician knows how to do that. Why do we care so much about a dynamic parameter as opposed to a static parameter? Well, this is a really fun study to talk about to demonstrate this point, that pressure and flow are not equal to each other in this case. So in 1944, they bled a group of Irish medical students until they fainted in this study. And that is just sort of hilarious because obviously we don't bleed people until they faint, and they were volunteers. Everyone was okay, even after they fainted. So I want to show you guys physiologically what's going on with this patient. So cardiac output, they start bleeding the volunteers. Cardiac output falls early, it falls linearly. We would expect this. All right, heart rate is going to climb up here to compensate. We would also expect the compensatory mechanisms in the body to kick in. Our bodies want to be well, and our bodies are designed to hang on to blood pressure no matter what. And so part of the challenge with blood pressure is the resilience of it, right? I mean, your body wants to maintain that homeostasis, and so it's going to hold on to that blood pressure until it simply can't anymore. So you'll notice we had a slight drop in our blood pressure here and a small rebound, and then it really tanked once the volunteers actually fainted, which is just honestly a little bit late to be intervening. So the point is that technically a stroke volume and cardiac output are going to change ahead of blood pressure, and by looking at those parameters, you can actually determine ahead of blood pressure if your patient has a worsening or developing perfusion problem. So you're going to be able to just have a kind of a look around the corner on what's going on with your patient. So it's a separate lecture that involves some very exciting physics of things to talk about pressure and flow, but we just want to keep that in the back of our mind that when by the time we see a patient who's hypotensive, they've already been compensating for an indeterminate length of time. All right, let's talk about how to actually implement a dynamic assessment. You can do a PLR if you have the ability to look at stroke volume index in real time. We talked about some ways to look at what were dynamic parameters already. So a PLR is when your patient is, you're looking at stroke volume index percent change continuously. Why am I talking so much about stroke volume index percent change when there are other parameters? It's because it's the most sensitive and most specific, and a PLR is actually also the most sensitive and specific in terms of accuracy. And so we want to, I'm just going to live there and talk about those two things. The PLR, as my ICU educator Molly would say, is the only bolus you can take back, and so it's also just a fan favorite just across ICUs and EDs, because if you are nervous to give your patient fluid, you can actually do a PLR and then sit them back up and the blood goes right back to their legs. So that's where we're going to focus this conversation. It's also, depending on the technology you have at the bedside, non-invasive and can be nurse-driven. So those are reasons why people tend to gravitate toward, clinicians tend to gravitate toward doing a passive leg raise to determine if their patient is fluid responsive, again, provided they can look at stroke volume index percent change in real time. All right, so you would set your patient up in bed looking at stroke volume index for about 3 minutes to get a nice baseline. If we don't know where we started, then where we went is not going to make any sense, right? And then you lay the patient back once you get a nice stable baseline, and you raise the legs. And this returns in an average size adult roughly 250 to 300 cc's of blood through the calves, from the calves, through the IVC, and it hits the heart. Most people reach their maximum stroke volume index in about 90 seconds, so it's very fast. And provided your patient can tolerate laying flat, you're able to determine what happened to the stroke volume. So you measure the percent change. A stroke volume index that climbs 10% or more means your patient is likely to increase their cardiac output in response to further fluid of 500 cc's. That's where it comes from in the literature. So if you get an order in response to a PLR, fluid responsive, maybe your patient's fluid responsive, 25% fluid responsive, let's say, and they order 500, just know that from the literature, that's what a PLR is highly predictive of, if they're fluid responsive. If your patient is not fluid responsive, then that's where we need to continue the conversation, because that's often a clinical crossroads where we're saying, well, does this patient need fluid or does this patient need a pressor? And what about the patient who's hanging out in the ICU on low-dose Levophed for 5 days and we can't wean the pressor? So there are opportunities here to actually implement a dynamic assessment of fluid responsiveness at different points, in the clinical conversation when you're trying to determine what does your patient actually need. All right, the question for us should always be asking about patient outcomes. So does this approach change outcomes? If I actually, after the weight-based fluid, if I implement a dynamic assessment of fluid responsiveness, is this going to actually change outcomes for my patient? The answer to that is yes. So this study was, the University of Kansas Medical Center did a single center retrospective study where they had roughly 200 sepsis and septic shock patients. All of them got the weight-based fluid, and then after that point they were split into two groups, and there was a stroke volume guided group and a usual care group. So at any point in time, if the patient had low blood pressure, oliguria, altered mental status, modeling, we were concerned about the patient. In other words, they were concerned. They would do, in the stroke volume guided group, they would get a dynamic assessment prior to getting more fluid. And then in the usual care group, if any of those things occurred, they would get fluid according to usual care, which we would normally give fluid if our patient were oliguric, or if they had altered mental status, or maybe were febrile and also maybe hypotensive, and tachycardic, or maybe had modeling signs and symptoms of hypoperfusion. In the stroke volume guided group versus the usual care group, this is what they found. Overall, there was a reduced fluid balance, reduced ICU length of stay, less time on vasopressor, so 32 versus 64 hours, and less time on mechanical ventilation, less need for dialysis, and there's that 53% fluid responsiveness again. So this idea really formed a very solid hypothesis of can we do a prospective study is the clinicians were asking themselves this question on looking prospectively in multiple different centers, which is what formed the hypothesis for the FRESH trial. So the fluid response evaluation in sepsis, hypotension, and shock was really kind of predicated on this idea of, can we do a prospective multi-center randomized trial where we're actually able to determine whether or not stroke volume guided fluid resuscitation in sepsis and in sepsis, hypotension, and shock does it change outcomes? So the answer to that is yes. Spoiler alert. But this, I wanted to show you guys the clinical pathway, the protocol that they used. So again, they had all the patients receive the lactate, blood cultures, antibiotics, whey-based fluid, and then after that point you had two groups, your usual care group and your PLR group. So after that point in the PLR group, if the MAP was less than 65, systolic was less than 90, blood pressure rapidly trending lower, oliguric, or really if there was a sign or symptom of hypoperfusion prior to getting any more fluid, they would get a PLR. If they were not fluid responsive, they moved toward the pressor arm, and you can see that on the protocol on your screen. If they were fluid responsive, they had a protocol for giving the patient more fluid. In the usual care group, they got fluid according to usual care, which we've just kind of talked about what that is. All right, so the stroke volume guided fluid resuscitation resulted in better outcomes, so there was less need for renal replacement therapy, there was less need for mechanical ventilation, and more patients were actually discharged home as opposed to skilled nursing. So one of the key takeaways, and for the sake of time, I'm trying to go quickly through this, but one of the key takeaways is that physiologically informed fluid and vasopressor resuscitation using passive leg raised induced stroke volume change to guide management of septic shock is safe and demonstrated lower net fluid balance and reductions in the risk of renal and respiratory failure. So dynamic assessments to guide fluid administration may improve outcomes for septic shock patients compared with usual care. All right, what about early vasopressors? So this study just came out actually this summer. So fluids and early vasopressors in the management of septic shock, do we have the right answers yet? And I wanted to pull forward some of these points from their abstract, and it's linked here for your full review and for your reading. But essentially they say this: complications of fluid over resuscitation further delay organ recovery. We know that that's true. Prolonged ICU and hospital length of stay and increased mortality. We've already talked about these things. The only reason for administering intravenous fluids in a patient with circulatory shock is to increase the mean systemic filling pressure in a patient who is volume responsive, such that cardiac output also increases. We've talked about that as well, especially with the 50% statistic. And then based on current evidence, the very early use of norepinephrine and its combination with smaller amounts of IV fluids in fluid-responsive hypotensive septic shock patients seems to be a safe strategy with better management results compared to large volume fluids before vasopressor initiation. Vasopressor therapy should be initiated as soon as possible in patients with septic shock. We also had another study that I read this summer from Monet et al., evidence for a personalized early start of norepinephrine in septic shock. And they also talk about duration and depth of hypotension are strongly associated with poor outcomes in septic shock, pulling straight just from their abstract. But one of the things I wanted to show you guys as well is that to add to the conversation for your curiosity and for you to investigate, is they say this: logically it should first be addressed to patients with profound hypotension. They're talking about the start of norepinephrine when the arterial tone is very low, as suggested by a low diastolic blood pressure or by a high diastolic shock index, which is also the diastolic shock index and low diastolic pressure, additional parameters that clinicians are using to guide the diagnosis of shock states. So more tools in your tool belt to, and this is, you guys can continue to review this and read it for you to consider in terms of when should we start a vasopressor. Now, peripheral leave-a-fed policies in emergency departments are starting to be a lot more ubiquitous, it seems, in medicine because of this reason of, especially if your patient is not responding to the fluid and their blood pressure is just not responding, and we've got that refractory hypotension. From Dr. Sanchez's lead author, he says this in the first paper I mentioned, the fluids and early vasopressors in the management of septic shock. he says this: perhaps all these strategies are appropriate as long as the fluid therapy is personalized, as something that seems as simple as administering fluids can become a very complex process with catastrophic consequences for the patient when it is not done correctly. It is prudent to determine beforehand the volume responsiveness in a patient with septic shock. So just considering really the prudence of continuing with IV fluid. This is where we're going to end the conversation, because I really want to focus in on what's the point of what we're doing here when we think about the patho of sepsis and we understand the treatment. What are we trying to do? Well, we're trying to actually maximize the oxygen delivery and correct the hypoperfusion. We're getting those antibiotics on board early. We're fluid resuscitating a patient. But when we look at the oxygen delivery equation, and this is helpful too for our novice nurses as well, is I obviously as a nursing professor have a very, very tender place in my fluid responsive heart for them. When I look at this, it helps me understand what I'm doing and why I'm doing it. So on the right-hand side of the oxygen delivery equation, I'm not really going to address that because I'm assuming for oxygen content, if your patient is bleeding, you're handling it, and I'm assuming that if your patient is having some kind of either ventilation issue or oxygenation issue, that you are also handling that. All right, so on the left-hand side, I'm also not going to talk about rhythm and rate and those sorts of things, because I'm assuming if your patient is in a wicked rhythm, you are also handling that, and especially if the rhythm is so gnarly that it's actually impacting their cardiac output. Where I want to focus our conversation is right around the stroke volume piece of the oxygen delivery equation, because there's so much we can do to actually help preload, afterload, and contractility, and that's what I want to walk you through. So my nurse guru Karen taught me this idea of pulling a lever of perfusion in, and it just clicked in my brain in a way that it never had before. And over time, I've built out some additional things here that help me understand. So this is in service to you, and I hope it's helpful when we think about fluids or pressors, and then we think about putting the pressors on earlier, but we're not really sure. Does my patient need fluid? Do they need a pressor? What do they actually need? And this can actually, I think, help us. So when our patient presents to us with a perfusion deficit like oliguria, hypotension, altered mental status, tachycardia, knee modeling, any of those things, and we're asking ourselves, does our patient need more fluid? Then we can talk about preload, giving our patient preload. So preload, and I'm aware that this is an oversimplification, but just go with me on this. So preload is the amount of volume sitting in the ventricle prior to each beat. That's why it's called preload. Preload, they named the thing for the thing that it is, I think. And the way that we're going to measure it is by looking at stroke volume and stroke volume index. Again, I know it's a simplification, but I want you to remember V for volume. So one of the scariest things about these conversations is when we feel overwhelmed and don't understand hemodynamics. So we're going to try to simplify it so that you can take these conversations back to your new grads and to your novice nurses and help them really understand what's going on. So the normal heart, what's a normal heart rate range? It's 60 to 100. Guess what? Your normal stroke volume is also 60 to 100, and roughly half that is your normal stroke volume index. So that's a really simple way to remember, because we're looking at stroke volume index percent change, and one of the biggest questions I get is, Stephanie, I don't actually know what stroke volume is. So if heart rate is how fast my heart is beating, then stroke volume is the amount of blood that's coming out with every beat of my heart, okay? And then the normal range is the heart rate range trick is how I remember. This is the other way I remember. What is preload, or what is stroke volume, and what am I doing with this parameter? Well, I have seen that the cardiac output monitors on the marketplace enable you to change the colors. And so I started changing stroke volume index to blue, and I remember that this has to do with fluid because it's blue like water. So bear with me here. I know my color coding tricks are a little silly, but they really do work, especially when you're overwhelmed. All right, so I can pull the preload lever and give my patient fluid, but am I really going to do that prior to assessing for fluid responsiveness? Well, especially after the weight-based fluid, according to the literature, the answer to that would be no. I'm going to do a PLR or a rapid fluid bolus prior to giving any more fluid, because we know that only 50% of hemodynamically unstable patients are going to increase their cardiac output in response to further fluid. We know that fluid is an independent predictor of mortality, and we know that fluid overload is going to increase complications for patients. So there are all those sorts of things we want to keep in mind prior to pulling the preload lever. We want to go ahead and do that dynamic assessment. Another way that we can help maximize perfusion in our patient is by looking at their afterload. Afterload is working after the heart with downstream blood flow. That's what it's called, afterload. And we can look at TPR and TPRI. These are our surrogates for the more invasive version of SVR and SVRI, but the ranges are the same. I like to remember R for resistance, so total peripheral resistance, R for resistance. Here's our normal values. What's important to remember here is the lower the number, the more vasodilated our patients are, and the higher the number, the more vasoconstricted they are. And so this is where we get into the ability to have a conversation around, does my patient need a vasopressor? If they're not fluid responsive and their resistance is really low, well then maybe we can have that conversation about getting them on some levo, norepi. If you have the opportunity, I recommend turning your TPR or your SVRI purple, because I remember this by thinking purple for pressor, and that just helps me remember, oh, I've got fluid and I've got pressors, and purple for pressor. It's just an easy way to remember it. It's all right. All right, the third lever I can pull to maximize perfusion in my patient's body is the contractility lever. This is literally just the actual pumping action of my heart, and the primary way we're going to be measuring it here, again, I know this is an oversimplification, is cardiac output and cardiac index. I remember this C for contractility, and then obviously our normal values. Now here's the curious thing about contractility. Sometimes your cardiac index is low because your patient needs fluid. And sometimes it's low because your patient has some kind of a heart failure issue going on, or some other sort of thing that needs to be investigated. So when you think contractility, I want you to also be thinking curiosity. You need to get curious. Ask more questions. If your cardiac index is low, also look at your resistance. So remember, afterload and contractility have an inverse relationship. So the higher I go on my afterload, it obviously means my heart is going to have to work even harder to overcome all of that resistance to get blood out and pump around to the rest of my body. So with cardiac index, this is one where I'm often wanting people, I tell my students, you're going to want to have a conversation with your doctor, with your provider, around what is really going on with the heart. So we have volume, we have vessels, and we have our pump, or fluids, pressors, and inotropes, essentially. Technically, you could give a vasodilator, and that would also be pulling the afterload lever, but since we're talking about septic shock, we're thinking pressors. So when you're thinking about vasopressors and you're thinking about fluids and you're not sure when to pull the lever, you can do a dynamic assessment which will help you make an informed decision around the fluid. Now, other literature tells you about what type of fluid to give in terms of the amount. I've let you know that according to the literature, PLR is highly predictive of what the heart will do in response to 500 cc's of fluid. So that kind of helps you in your clinically in terms of fluid choice and amount of fluid. Please remember, too, that fluid responsiveness changes. Now, we don't have time to go into the beta-adrenergic effects of Levophed and why this might actually be, but in the FRESH trial that we looked at earlier, the average amount of PLRs throughout a 72-hour period was about 6 or more. So you don't want to just assess a patient for fluid responsiveness and say, oh, I'm done, I did it. When we have to actually have continuous conversations, especially as long as your patient is on a vasopressor. Technically, they're considered to be hemodynamically unstable. That's not a normal state. So hopefully zooming out and looking at this bird's eye view is helpful to you, because the reality is that we can talk about fluids and we can talk about pressors all day long, but when we're the person at the bedside trying to determine what it is that our patient needs, and we see all these values and they're very overwhelming, we really need to understand a simplified version. And so I hope that V for volume and R for resistance and C for contractility help you remember the purpose and the intent of why we're giving fluid to give volume, why we're giving a pressor to give resistance back to a patient who's lost it in a shock state, and why we might even in contractility be giving fluid Or sometimes an inotrope, I call that a critical care cocktail when we're doing all three. But hopefully this is helpful to you, and I really just encourage you to continue to dive into the literature. Obviously, I think it's really fun. That's my inner nurse nerd coming out, but this is how we can continue to have really powerful discussions and service to our patients everywhere. So thank you so much for your time today. May our hearts stay responsive, and I will see you later.